Good afternoon, everyone. This is Brian Robson, the Executive Clinical Director here at Healthcare Improvement Scotland, and welcome. Welcome to the 10th in our series of QI Connect webinars, in fact the last of 2014. We'll talk about 2015 at the end of the call. This series of webinars came from a request from our national clinical leads here at Healthcare Improvement Scotland to connect frontline clinicians interested in quality improvement with international leaders in the field of improvement. They asked that we make the sessions short, accessible and recorded to allow access at a time that suited them. And here we are 10 episodes into this series. I'm going to hand you over to Jennifer Graham just now, who's going to explain a little bit about how to use WebEx and how we'll get the most out of this interactive hour. Good afternoon, Jennifer.
Thanks, Brian. Thanks everyone who's joined us on the call today. So just a few tips for a successful WebEx. We want this to be as interactive and as fun as we can. So I'm going to speak to you in a little moment about how to use the chat box. So we really encourage everyone to post your comments and questions throughout the session and really get a good dialogue going. If you're having any technical difficulties, if you could message me through the WebEx chat function, or if you could use the telephone number there, 07929 049 216, and we'll get back to you. So just a little bit of orientation of WebEx. So as I mentioned before, we want to really get this discussion going. So what you can do on the bottom right-hand side of your screen, you can actually just type in any messages or questions as Elaine's presentation unfolds. We'd encourage you to send messages to all participants, and Brian's just showing us there, sending a message to everyone, which is great. As we said, we want this to be a really fun session, so we're going to just trying to get a kind of picture of where everyone's going to be joining us from. So this is the interactive part of it. So if at the top of your screen you can see a toolbar and there's a blue arrow at the left hand side, if you could just all click on the blue arrow and just click on the map to where you're actually dialing in from.
I see I'm mid-Atlantic, but we've got Fiona and Carmen. So we're populating Scotland. Jennifer.
That's perfect. I'll just hand it back to you.
Great. Now, we're going to come back to those arrows just in a little moment. But just to say that the QI Connect series has really gone from strength to strength through the year. We're absolutely delighted with the reach of this series. We've now got 184 organisations since January this year who are registered to join our events for the QI Connect. Where those people are coming from is from a number of agencies. We have more than 185 agencies joining us. These are the agencies. When we first started this series of calls, you will recall that we had just one slide with a small number of logos. We now have not one slide, not two slides, not 3 slides, but actually not 4 slides, but actually 5 slides of organisations that are joining us here on the call today. And we're absolutely delighted to be calling out that we've got 3 new organisations joining us today. We have the Concord Hospital from Australia, from Sydney in Australia. Welcome to them. We have Go to My Doctors, which is an online website in England and obviously elsewhere. And we also have the Department of Health, Social Services and Public Safety in Northern Ireland. So welcome to our new organisations who are joining us for this call. And of course, as Jennifer mentioned, we have an amazing global reach, and we're delighted to say that we now have 42 countries that are connecting in with us, or people in those countries connecting in with us. And as usual, for those of you who've joined QI Connect before, we'd like you to get your fingers on the buzzer, get your finger on that little blue arrow, because I'm going to name the latest country that's joining us. And I'd like the first person to put their arrow on that button, on the flag, then they will be getting a special prize. So the new country is Sierra Leone. Sierra Leone. So let's just see who's going to be winning the prize today. We're a bit slower today in terms of the flags. Anyone know where? You can take a guess. It's okay to take a guess. Thanks, Oliver. Thanks, Fiona. And okay, Carmen Forrest. Well done, Carmen. Carmen, in the bottom right of the screen there, the third flag from the bottom right. Carmen, that is Sierra Leone. Well done, Carmen. Now this week there's a special story behind the Sierra Leone flag. We're all very familiar with the human tragedy that's going on in West Africa, and with regard to the Ebola outbreak. And we are proud to say that one of our Scottish Patient Safety Fellows, Roger Alcock, who is an A&E consultant in paediatrics in NHS Forth Valley, is out there with a cohort of NHS staff who are working with the people out there with the folks with Ebola. We're absolutely very proud of you, and good luck with your work, and thank you for joining QI Connect today. Thank you for that. We're also delighted to say that the ISQA organisation has featured the QI Connect webinar series as an approved resource within our fellowship programme. So we're absolutely delighted with that reach also. And of course, we're absolutely delighted to have Twitter, and please tweet merrily at #HISQIConnect. We'd like to spread the word loudly. And of course, welcome again to the QI Connect team. We have Jennifer Graham here, we have Carmen Forrest, and we have Ross Stewart. And many others are helping us behind the scenes, but just to put a face to the name, welcome to you all. And just to introduce also, you'll meet Fiona later on in the call, but Fiona Dagbell is our Chief Nurse, Midwife and Allied Health Professional here at Healthcare Improvement Scotland. And as you know, the way this series works is that the speakers have an opportunity to be questioned from one key questioner, and today that will be Fiona Dagbell. So looking forward to Fiona's question. So that brings us to today's speaker, another international expert in quality improvement. Elaine Inglesby Burke is the Executive Lead for Nursing Governance, Patient Safety and Quality Improvement, and also the Deputy Chief Executive at Salford Healthcare. Elaine is a registered nurse and has specialist nursing in critical care and general medicine. Elaine continues in clinical practice with regular clinical shifts and executive safety shifts with frontline staff. She is a Florence Nightingale Leadership Scholar and took the opportunity to undertake advanced leadership and quality improvement training at Harvard and also at the IHI in Cambridge, Massachusetts. Elaine was also the nurse advisor on the Berwick Review Group, a promise to learn, a commitment to act. And we're absolutely delighted to have Elaine with us this afternoon. Good afternoon, Elaine.
Good afternoon. Thanks, Brian, for that introduction.
Now, Elaine, you now have the ball, so please, we're looking forward to your talk. Thank you very much indeed.
Okay. Thank you. So, good afternoon, everybody. So, as I've already been introduced, I'm the Chief Nurse here at Salford Royal, and I want to preface my presentation, I guess, with something that I believe particularly passionately about, which is longevity of leadership in an organisation to enable a change in culture. So my starter for 10 is I'm in my 11th year now at Salford Royal as its Chief Nurse. So everything I'm about to share with you, I guess, comes from a long journey that a team have worked together on for at least 7 years. So preface it with that. A promise to learn and a commitment to act was the title of the Don Berwick review into patient safety in NHS England. And that patient safety review was in response to the Francis report. And I'm not going to spend a lot of time on this because I think globally you can't not know what the Francis report was about. But suffice to say that it was a failure of the board in that organisation to listen to patients' concerns and to correct deficiencies and tackle what was described as an insidious negative culture that tolerated poor standards. And there was significant clinical disengagement from management and leadership responsibilities to the front line. I've split the 290 recommendations into 5 categories, and I hope what I'm about to present will give you a sense of what a provider organisation in particular can do to try and address some of these categories, predominantly being the fundamental standards and measures of compliance, being open and transparent, and seeing an improvement in compassionate caring and committed nursing, seeing stronger healthcare leadership, and actually using information to improve care and systems. So I've sort of split up Don's recommendations about improving the safety of patients in England into 6 key areas that I believe are fundamental to changing the culture in an organisation, but particularly changing the culture in an organisation where clinicians are leading at the front line. And so I'm going to take each of these and describe what we've done here in Salford Royal to try and address and move that improving safety forward. So first and foremost, leadership, which we believe equals commitment, visibility, encouragement and compassion from all leaders, not just the clinical leaders in an organisation. And we've been doing walkarounds in this organisation since 2007, since we returned from the Exec Quality Academy in Boston with IHI. And we found they worked really well for us. We had a script when we went out to meet with staff. Staff knew when we were coming, and they were great for starting the dialogue on when do you think the next harm might occur on the ward, what are the systems that are frustrating you. But we've found that they're really not good enough. They're not enough to actually break down the barriers of a hierarchy in an organisation. And we do know that the currency of leadership in an organisation is what the leaders pay attention to. So we've found that to get situational awareness, we now do work with. So we actually work alongside our staff, and that's every executive, whether they're a clinician or not, and every senior manager, whether they're a clinician or not, actually put a uniform on appropriate to the area that they're about to work with and spend 4 hours in those areas, and we do that every month. And that helps us to understand how the people and the systems operate at the front line. It helps us to understand the complexity of the roles, of the jobs that we're asking them to fulfill. It also helps us to recognise that there is a middle tier in an organisation. So we've done lots of work around engaging with our front line. But actually, we were a little naive in that what we thought we were doing was absolutely the right thing to do, and I guess it was. The proof has been in the outcomes. But it has been at a cost to the middle tier in our organisation, where they have felt less engaged. And so actually, as executives and senior leaders, we almost bypass them. So leaders need supporting and staff need supporting at all levels in an organisation. The commitment, visibility, encouragement and compassion needs to find its way into the organisational development and the culture of the organisation. And so accountability for what we expect to be achieved in the organisation, but hierarchy, no. We've spent several years trying to break down the hierarchy by being equals across the organisation, by being clear that we need to listen to our staff. And I guess the most important thing for us is that we must be authentic. We must, in place of arrogance, have humility. We must recognise that we don't always get it right. In fact, probably more often than not, there are problems within our systems that are frustrating our staff, our patients and their carers. And so I guess as leaders, we are very clear that we can aggregate up in our organisation and we can satisfy ourselves that we're doing a great job. But when we dig a few levels down in the organisation, we then start to test what's the percentage of time that leaders spend on safety versus operational pressures. And we've been quite surprised in Salford at the outcomes from that operationally tends to supersede the safety issues in the organisation. So moving on to measure transparency and understanding variation. As I've already said, at organisational level, we can assure ourselves, or indeed reassure ourselves, that we're doing really well. We have an enviable HSMR and shimmy. We have enviable outcomes on pressure ulcers, on falls, on the 4 national harms that are measured. But actually, when we take that data and we go down and look deep in the organisation, what does that picture tell us? Are all the harms coming from 1 or 2 areas? So if we aggregate up, we're really pleased with what we find. But we actually go now and look for variation across the organisation. And we believe at sub-organisation and deep down in the organisation, these are the areas that we need to understand the variability on. So we need to understand the measures of harm that will be occurring at service and ward level. We need to understand the perspective of our patients and their families, not just in national surveys, but at surveys that are taking place at the bedside, where they can log on online and tell us at any point in a 24-hour period how they're feeling. We need information on practices that encourage the monitoring on safety. We're really, really keen on understanding data on staff feedback, staff satisfaction, how they feel and whether they're delivering a quality of service that they'd be happy for their mum to receive. Staffing levels, incident reports, we feel it's really important to get down to that level of detail at ward and departmental level. So I guess a question I would ask was, do you know how well your trust or organisation performs on each of the indicators identified here? And you'll know how your trust possibly performing on them, but do you know how each of your wards and departments are? So we started by surveying the safety culture in individual wards and departments, and what a surprise we got. So we perform really well on national patient and staff satisfaction surveys. We perform really well on the number of incidents that are reported across the trust compared to our peers in the NHS. But actually, when you really get down to understanding the culture of safety in our wards and departments, we saw a very different story. So safety culture surveys can look at the culture of safety, the teamwork and the communication that's operating at department and ward level. It's great for understanding variation between units and across disciplines, and it should definitely only be used as a learning and intervention tool. It should never be used for performance management. And so here's just some outcomes from some of our culture survey work. We do know now that culture is local. So we can talk about the organisational culture, but actually when you get down into individual wards and departments, it is very local, and finding variation around that local culture is really key for improving safety. So you can see here 2 different wards, Ward 1 and Ward 2, same questions asked of staff across those wards, predominantly nursing and medical staff, and you can see that if we applied the same methodology and the same interventions across the whole organisation, we probably wouldn't get very far. We need to really find the local variation and work with that local variation. So what you can see here is in Ward 1 that none of the doctors felt it was difficult to discuss errors, yet 40% of the nurses did. And in Ward 2, 40% of the doctors felt it was difficult and only 10% of the nurses did. So how we approach individual wards and departments to understand their culture and to understand what they need to improve, we need to understand the variation in the culture that's operating. So same hospital, different cultures, vastly different cultures on different wards. So we do go looking for variation, and this is our nursing assessment and accreditation system. And it's been operating now for about 5 years. It was a slow burn, and that was intentional. So there are 13 standards with multiple criteria within them, and the standards reflect leadership, environment and care. They reflect best available evidence, they reflect the CQC standards, the Essence of Care, NHSLA. So they're all national standards that are available to us. And the wards are assessed independently and consistently by the same team. So it is independent of the ward themselves. This is not peer assessment and it's not self-assessment. And if they score red, they will be assessed within 6 to 8 weeks. If they score amber, they'll be assessed within 4 months, and if they score green, it will be 8 months. And the key here is sustainability. So you have to achieve green 3 times consecutively to be able to apply to a board subcommittee and produce a portfolio evidence and present to be accredited at what we call safe, clean and personal every time. And if you do achieve that accreditation, the ward manager has earned autonomy over her ward and department for the recruitment of staff and for the means with which she achieves the standards, and she also earns the title ward matron. And I'm sure there'll be plenty of questions asking me, do they get a reward financially? And the first 4 wards that went forward were asked if they felt that their salary should be improved as a consequence, and unanimously they said no, because the achievements of these standards are not down to a single individual. In order to achieve the standards requires a team to operate cohesively and for members of that team to own areas of the standards for themselves. So it was a proud moment for me when nursing turned down money for great teamwork. What we have found with this system is that great leadership absolutely plays out with great care. That where we've got outstanding leaders, we've got skate wards who have sustained it for 3 and 4 years now. Where we've got red wards, if they get red twice consecutively, everybody across the organisation knows that the ward manager, we will look for mitigation, and if there isn't any mitigation, the ward manager is held to account for those standards and is enabled to find a job elsewhere in the organisation. And I can say without doubt 4 ward managers have been removed to date, and they have been what we describe as square pegs in round holes. They are outstanding clinicians, but they lack and probably will never have the leadership skills to enable distributive leadership within their wards and departments. So it works well for us, and it is our sustainability model for fundamental standards and for our quality improvement system. So when we develop a change package that has demonstrated to result in an improvement, that change package is built into this system, and that's how we measure the reliability of the change package in an ongoing way. Transparency is really important to us here at Salford, so we fundamentally share our harms, we share our nursing assessment and accreditation system, and we share our staffing levels at the entrance to every ward. And this is unified across the organisation in every ward and department. When you walk onto the ward, this is the first thing you see, and there'll be a sink underneath it. asking you to wash your hands before you enter the ward. And so we flag up our MRSA bacteremia rates, our Clostridium difficile rates, our falls and our pressure ulcers, and we don't measure whether there were 4 last month or 8 the month before. We're really interested in the days in between, because we know that that's what engages our staff. They don't want to have a 0 on this board, and they're really, really proud when they can say, it's been 360 days since a pressure ulcer in my ward. It really does allow them to pay attention to the right things. So they use data every day to drive up their standards. They use statistical process control charts to track whether or not the changes are resulting in an improvement in their environment. So we build capability, we use improvement science, and importantly, we network our learning. And isn't that why we're here today? So this is just an outcome from one of our quality improvement collaboratives, which was about reducing cardiac arrests outside of critical care areas or high care areas. And I won't go into detail here, but we use the Breakthrough Series collaborative and the model for improvement here in this organisation, and it's been outstandingly successful on multiple levels, not least deep staff engagement with our frontline, deep staff engagement with our frontline. And so this is the change package that we use across the organisation now. It's been tried and tested using PDSA in our wards and departments. They tried and tested. They absolutely acknowledged that failure was our friend, that if they tried something and it didn't work on 1 and then it didn't work on 5 patients, then don't bother trying it. We don't want to scale up and spread something that doesn't work. And so they came up with these 7 changes. They're tried and tested in this organisation. We've seen a reduction of 70% of cardiac arrests outside of high care areas in this organisation by utilising the tests of change that our own staff found in this organisation. We don't have a medical outreach team. We don't have a critical care outreach team. We've empowered our own staff to find solutions to their problems, and they found it in spades for us in this organisation. So we use Breakthrough Series Collaborative for the majority of our large-scale quality improvement across the organisation. So QI capability building is part of what we do now. So we have an improvement directorate. We use lean methodology. We use the Dartmouth Clinical Microsystems training. We've had over half our staff now go through collaborative learning. We have a clinical quality academy. So multiple ways of engaging our staff to get to, I guess, a Kaiser Permanente model, where we have some experts at the top of the pyramid, but actually our frontline teams and the majority of our staff are experts themselves in how to use the model for improvement in their wards and departments. It would be really unusual now to go onto our wards and departments and not hear them say, we changed our visiting hours, we ran some tests of change, and we found that the best one that worked for staff and patients was X. It is the language that we use across the organisation now. So staffing levels and our staff are equally important. So Berwick said that staffing levels should be consistent with the scientific evidence, and for those nurses of you out there, you'll know that we should feel pretty ashamed actually that the national evidence base for safe staffing is very, very poor. So come on guys, we've got some work to do. That staffing should be adjusted for patient acuity and local context, and it should be made public and easily accessible to patients and carers. And Don Berwick charged NICE to produce definitive guidance. So the National Institute for Clinical Excellence have already produced the first guidance on acute, and we're about to release the accident and emergency. We publish our staffing at the entrance to every ward, and we we take it to the board every month. Boards should take full responsibility, and Salford Royal does. We've got processes in place where we capture our staffing data 4 hours every day, every 4 hours every day. We have a culture where staff are able to raise concerns about staffing. We take a multidisciplinary approach, and we make time in our staffing levels to offer direct and indirect care and contact hours. That's really important. I think there is a growing feeling across the country that indirect contact hours aren't valuable, and we believe they are extremely valuable, and they have equal value to direct care. If you're to plan care appropriately to deliver the right outcomes for patients, then you need to spend time assessing and documenting the care that you're giving. So listening to staff, our current practice is through our clinical governance, our work with, our walk rounds, appraisals, incident reporting, but we're looking at the moment at what it might look like in the future. We're really keen on a system that we saw out in the Southern Hemisphere, in Australia and New Zealand, where you can at any point in time see where your staffing matches your patient nursing hours and demand. So we're moving on that pretty quickly. Problems are investigated until they're proven otherwise, and I think that's been a lesson for us here, that we've had 7 years of great movement along the quality improvement journey, and we're always surprised when our staff tell us that there's a problem and we go, oh, surely not. And actually we've moved into the domain now that says there'll always be a grain of truth in what your staff tell you. And so we listen to staff, and we're prepared to hear what we would have probably considered before to be unthinkable. And we're in the ball game now of trying to understand what merits a concern, what merits closing a theatre list if our staff are raising concerns, what merits stopping admitting patients to a ward if we feel there is a standard that says I wouldn't want my mum to be cared for in that ward. Then why would anybody else's mum? Why would anybody else's mum be blindly admitted to that ward and then not understand the systems that are operating? We know that our data is slow to catch up with the reality of what's happening in the organisation. So we know from an HSMR perspective, we're pretty good. We've got a low HSMR, but actually we've talked about variability, and our staff tell us about our variability. We need to understand what the real issues are and what the perceived issues are. And often there isn't a great gap between perception and reality if we could just sit down and speak to our staff. So listening to our staff, normalising critical language, looking at world-class communication systems, and being aware that our staff need to operate in a psychologically safe environment for our patients to receive safe care. Sorry, guys. And so down to patients now, and I've not left them till last because I believe they're last. I've left them till last because I think it's the important message I want to leave us with. So Mark Holland is a young man who had a specialist metabolic, complex metabolic disorder since birth, a genetic metabolic disease, and his first adult inpatient was with Salford Royal. It was his first transition into adult services, and within 5 days of transitioning into adult services from the paediatric service, he lost his life. And he lost his life in our organisation because we didn't listen to his mum. And she was the expert in his care, and he had learning disabilities. And we didn't listen from top to bottom, from the expert consultant to the ward sister on the ward, to the junior doctor, to the matron, to pals. She had the emergency protocol in her handbag that would be used in the paediatric hospital, and we said, but he's in an adult service now and we do things differently. And oh, we did do it differently because he lost his life as a consequence of us not listening. There was no other reason for him to lose his life in this organisation. And we learned from that, and we learned the hard way for a mum to lose her son. But we have found that it is a common theme in serious incidents that the patient and or their family knew something was going wrong, told staff and weren't listened to. And so as a consequence of Mark's story and Mark's tragedy, we now have the Mark Holland Metabolic Unit. So he does live on. And we developed a help system, which is called Helping to Empower Loved Ones and Patients. This is visible at the entrance to every ward, and it's visible on every locker, and we give cards out, and it basically asks patients and their families if they ever feel vulnerable and don't feel able to share it with staff, or they've shared it with staff and they've not been heard, to ring the number. And the number goes through to the clinical site coordinator. She knows when it's a help call because it's a different ring. And if she visits within 30 minutes, if she can't resolve the issue, it goes to the clinical director. They are 2 calls away from the nurse or medical director, whatever time of day, whatever day of the week. It has never, ever been escalated to myself or the medical director. And we've not had an issue with patients not being heard in this type of environment. So the patient voice should be heard at every level of the service. We should be challenging the National Patient Survey results, because is being comparatively better than average good enough for your mum? It's definitely not good enough for mine. We use a lot of shared decision making, and we've just started to use shadow coaching, where we're encouraging non-clinical staff to shadow clinical staff in clinics and on ward rounds, and then taking the opportunity at the end of those clinics and ward rounds to give feedback on how it might have felt if they had been a patient and non-clinician. We're moving now into patients being able to undertake that shadow coaching. We're finding out what matters most to our patients, and not just through surveys, but personally for each and every individual. And so this is the best, I guess, of what we do in Salford about listening to patients, apart from the surveys. So we have boards at the back of every bed, and we ask what matters most to you. And so you can see we've got the patient's name, we've got the patient's preferred name, we've got the consultant, the nurse, and you'll see there a small box in the corner. That's for the nurse's photograph, so that on every shift, as the nurse changes, the photograph of the nurse who is looking after you is highly visible to you and your family. So it's easy to identify the nurse who will be able to answer your questions. And we ask the patient what matters most to you while you're in our care. And we ask their permission, can we flag this at the back of the bed? And then we ask them, before they go home, did we deliver what mattered most to you? And we find that that's the most powerful piece of information that we need to change the way we deliver care to our patients. Not what we think as healthcare professions matters most to patients, but what actually matters to them. And there are some of the examples that we've had from our patients. So Berwick for me was quality first, but safety above all. And so we should all be following the lead of organisations who've successfully cracked a problem. We should steal what they've done shamelessly, and we should use it wisely in our own organisations. So thank you, IHI, and everybody else up and down the country. We should bring staff together to solve problems collaboratively, because I can't solve the problems at board level. Our staff understand the complexity of the systems that they're operating in, and believe me, you get them together and you give them the tools and they will come up with the solutions. And those solutions will be sustainable because they found them. So in summary, I believe leadership is the currency, that staff will pay attention to what leaders pay attention to. Find new ways to listen to our staff. find new ways to listen to our patients other than surveys. Measure and know the variation across your trust, because it will give you a very different picture from the aggregate data. Pay attention to safe staffing. Don't expect your staff, our staff, to deliver great service if we tie their hands behind their back because there aren't enough to deliver it. We don't need to wait for anybody to tell us to do it. We can start making the changes today. And so for me as a chief nurse, whether I'm a nurse or whether I'm a healthcare professional or a member of staff in this trust, I actually saw Francis and definitely the Berwick Review as our promise to learn and our commitment to act. So thank you.
Elaine, thank you so much. A very powerful talk, and certainly the chat box was full of people agreeing with what you were saying and kind of holding what you were saying and mirror up to themselves. Very, very powerful. Anne-Marie Kavanagh, who's the interim nurse director at the Golden Jubilee National Hospital here in Glasgow, said that they're working on work around the workforce tool and workload planning tools that will go some way to give us the evidence. But a lot of agreement in the chat box about the need to look for some more evidence around staffing, etc. Yeah. And Heidi May, who's the nurse director in NHS Highland, made a point as you were speaking around that this is not simply about the implementation of one thing, but a structured, strategic approach to a range of changes aimed at changing culture. She goes on to say it's impressive, and I think we would all agree. Now, let me pass you on, Elaine. Thank you again. Let me pass you on to Fiona Dagbell, our Chief Nurse, Midwife and Allied Health Professional here at Healthcare Improvement Scotland.
Elaine, thank you so much. That was really inspiring and really thoughtful. A great sort of distillation of Don Berwick's report, which is, of course, a promise to learn and a commitment to act. And really, thank you again for sharing the amazing work you're doing in Salford. Obviously, the clinical community here in Scotland, the same as everywhere else, has been really active in seeking to translate the learning into improved care for all people using healthcare services here in Scotland. So it was great to hear you speak about the nursing assessment and accreditation system. And I know you've already been sharing the standards with some of our nurse directors and their teams here in Scotland, and it's created great excitement. I guess for me, it's how easy are they to translate into different systems of care? I'm sure you're going to be able to tell me that's not the easiest thing.
So you're right, it's not the easiest thing, and I guess I need a bit of clarity. Do you mean into social care and community services or different specialties?
I guess we could say into different specialties, but however we are looking towards health and social care integration as a very real entity here in Scotland, so I'd be really interested to hear from both aspects. Okay,
so at a specialty level, we tailor the standards so that there are fundamental standards in here that apply whatever specialty around personalised care, but we tailor the standards so we have an accident and emergency, so the accident and emergency has been tailored to meet their needs. It's been tailored to meet the needs of our theatres, tailored to meet the needs of our critical care areas and our outpatient areas. So where there are subspecialties, we add in standards that would only apply to that subspecialty. We've also developed a community assessment and accreditation system. So we inherited community services 3 years ago, and we've been running the community system now for 2 years. Got some great results from that, and they are delivering great care out there, great care, with little resource compared to acute services, I have to say. And we've also developed a care homes assessment and accreditation system because we have a primary medical practice as part of our organisation that delivers primary medical care to residents in care homes. So we've adapted it to the care home sector. Does that help?
Yeah, Elaine, that's been really good to hear, and I think we could probably have a conversation about this, which would go on and on and on. So I know that you will probably be happy for us to share some of your details with others. But however, I know the dialogue is continuing with the executive nurse directors, and we'll aim to communicate to you through that channel. Brian.
Thank you very much, Fiona. Elaine, we have a question here from Jeanette Morrison from NHS Lothian. Jeanette's asking if you could say a little bit more about the person-centred care standard and how you're working with that and what that looks like on your in your area.
Okay. So thank you, because we thought we'd been doing quite a bit of work on person-centredness, but actually we're now into our third quality improvement strategy. So we're into our 7th year, and our next 3-year strategy has just been launched this month, and it very much is about person-centredness, because we realised we're still at the beginning of that journey. But the work that we've done to date has been predominantly around patient and family experience. So that I've described around what matters most to you. So we run clinics called What Matters Most to You clinics. So they're general clinics, but the consultant asks the question. So you'll have heard this from Maureen Biziano, which is not saying what's the matter with you, but we run clinics where the consultant says, so what matters most to you out of this consultation? And they have worked really, really well. So we haven't gone wholesale on that. We're still testing it out. We've got the What Matters Most to You boards. We have 6 always events in the organisation, in stark contrast to the never events, and they're publicly available. They're organisational always events, but we ask our wards and departments to translate those always events into their specific area, so around what matters most to the patients and the specialty that you're operating in. We collect real-time patient experience data via our Hospedia system so that we can respond in the moment, if you like, to actually resolve issues. We use intentional rounding in our community services, in our accident and emergency, and in all our wards and departments. And we do it hourly, and we finish every intentional round with, is there anything more I can do for you? So I'm going to say that's as far as we've gone with person-centredness. We've got such a long way to go. We've learned such a lot about person-centredness, and we're only touching the tip of it at the moment. I hope that helps.
Yeah, thank you very much for that, Elaine. Can I ask just a follow-up to that? So at these What Matters to You clinics, is there a kind of general thing that comes through, or is it truly individual?
Oh, it's truly individual. Would you like an example?
That would be super.
Yeah. So gastroenterology clinic, a lady came in and our consultant asked her, she was in her 30s, asked her, so what matters most to you for this consultation? And the feedback from the consultant said she was blown away by what she got, which was, why are you asking me? So most people are really taken aback by, is this a trick question? But what she got was, I come here on a regular basis. She has inflammatory bowel disease. So she's on and off steroids and has been for the last 10 years. And she said, what I want most of all, I understand the risks around steroids. I understand the risks to my health. But please, will you leave me on steroids for the next 12 months and let me get some normality in my life? Because I get normality and then you take me off it, and then I relapse and then I get normality and then you take me off it. And I'd like to take control, and can I have 12 months where I am in control and having a normal life? If we hadn't asked her what matters most to her, the consultant would have said, we need to just give you some time off the steroids and try something else. And something else never used to work. And so really, really powerful. That woman skipped out of the clinic. She knew what she needed to do if she was running into problems as a consequence of the steroids, and she took back control. But if we hadn't asked the question, she'd have gone with what we normally did with her. And so our consultants are finding it really, it's a scary place to be for them. But what they're finding is they're having a better relationship with patients, and patients are getting a better experience.
Thank you so much for that. It does give you real insight using that example of just how different it is, both for patients and for professionals. We have a question here again from Heidi May, from the Nurse Director in NHS Highland. As you know, we're always balancing finances. Great question here that says, there was no mention of finance in the presentation, which she said was excellent. Has the focus on quality helped to manage the finances? I.e., if you get the quality right, will finances follow?
Whoa. Gee, thanks, Heidi. I would have to say yes. Have I got the evidence that supports that? We're financially viable. We're having a really, really tough year this year when everybody else has had a tough 3 years. We're going to break even. I think we've got good outcomes, good productivity, efficiency data to show reduction in length of stay. So we know that the evidence is if you reduce your harms, you'll be able to reduce your length of stay. And we can say we're a pretty good performer on length of stay. We tend to use, we're just moving into a productivity and efficiency strategy, and we are going to use all our quality improvement methodology where we've seen fantastic results in quality and safety. We're going to use the same improvement techniques for our productivity efficiency because that's what engages our staff. And so we're just going to switch the lens. We're going to continue our quality and safety work, but we're going to switch the lens to reducing waste and see how that helps. But we tend not to discuss finance and quality in the same presentation because, A, we believe you can do this not on a shoestring, but you can change things at ward level without money. It just takes the right skills and the right techniques to get staff to think differently. I know that we're really fortunate here at Salford that the board put £1 million out of surplus 7 years ago, and they asked for a 10 million return on that. And I think they've had that in spades. So I'm not sure that's answered your question, Heidi, but we think it's what's kept our head above water for the last 7 years.
Thank you very much, Elaine. We have a question here from Anne McClinton, who's the Programme Manager of Person-Centred Health and Care at NHS Greater Glasgow and Clyde. Anne asks, have you found that you recruit staff in a different way to previously? And if so, what do you do differently?
Ooh, right. In pockets, we recruit staff differently. So we use values-based recruitment in the sense of we don't just recruit for your level of experience and whether you're registered or not, that we actually do put people through clinical skills stations. We also put people through a values-based interview. I think what we've found more than ever in the last probably 3 years, that we have become much more discerning around who we recruit. So you can have 10 people in front of you, and I'm going to use nursing as an example now. You can have 10 registered nurses in front of you and we'll only appoint 6. Whereas 5-6 years ago, we'd have said, they're all registered, there's 10 of them, give them a job. We are much more picky about actually the values and behaviours that you demonstrate at interview are as equal in value to the fact that you're a registered nurse and you may have the right clinical skills. So I think we have changed the way we recruit in that sense. And we do it with consultants as well. So values and behaviours are tested at medical consultant level as well.
Thanks very much for that, Elaine. And Heidi comes back to say thanks very much for the answer to the earlier question also. We have a question here from Rosemary Hector, who's the Programme Manager at the Quality Improvement Hub here at Healthcare Improvement Scotland. She was taken with your idea of asking for real-time feedback from patients, which she said was impressive. She asks, is there a risk of patients being inhibited by their context and being hesitant in telling what they really feel? Is that what you've found or not?
Gosh. Oh, I wish they on some occasions didn't tell us everything. I am only joking, by the way. No, people who feel able to share. We still get complaints. We still get PALS concerns raised. We're pleased about that, because even if you don't feel able to tell us in real time, the fact that you're able to tell us when you've gone home is still valuable to us as an organisation. So I think my answer is no, they don't all feel able to share with us, but some do, and we use that information in real time. We definitely, not all patients do. And we get complaints when they've gone home, when they could have had an opportunity to tell us while they were in. So not perfect by any stretch of the imagination.
Thank you very much. Question from Brian Robson, that's me. We had Sir Mike Richards on the last QI Connect, and he gave a very cogent outline of how he sees inspection of hospitals driving improvement. Could you tell us, you don't have to, we won't mention it to anybody else apart from the hundreds of people that may listen to this call, but can you tell us from your perspective, Elaine, how do you find the CQC inspection driving improvement?
Gosh, that is so mean. Okay, so we had a CQC inspection last October. We were part of the pilots. So feel free to have a look at our inspection. It's on their website. But I am currently preparing for another CQC inspection. They're coming back on the 12th, 13th and 14th of January to be able to rate us. And they're doing the whole organisation, including community services. So back to your question, I actually think they're doing pretty damn well at the moment, under extremely difficult circumstances. And it does feel like an inspection when they come in. I think they're still working on that. I think they're still working with inspection teams to say, you know what, guys, you're here to find great practice as well as hold a mirror up to say, look what else we found. I think if you look at their reports now, they are highlighting good practice. And I think that's a real move in the right direction. I think what I'd like to see from them is a compendium of practice across the country that they could actually give to organisations ahead of inspections to say, you might want to consider thinking about implementing X, Y and Z. And I think there's more to the implementation. So what I see is people taking ideas, and we've talked about it earlier, steal shamelessly but use it wisely. And the use it wisely for me is the meaningful way in which you implement something. So implementing something to tick a box for the CQC, you will be found out, and you should be found out, because our staff and our patients deserve better. But I think the CQC have come a long, long way in the last 12 months. But by their own admission, they've got a long way to go too. I think it's up to us as providers to use that information properly and not be offended when somebody holds a mirror up and says, I found a problem. Thank you for finding it. Thank you for sharing it. And now let's get on and do something about it, I guess is what I'd say.
Elaine, thank you so much for that. A very powerful talk, a talk that emphasised the importance of leadership, but emphasised the importance of humility, of honesty, and of sharing lessons in the interest of patient care. we're minded of the Maureen Bisignano phrase, never worry alone, and I'm sure that many of the folks on this call and will listen to the recording will be thinking, it sounds as though we've got some common areas to improve. Thank you very much again for the wonderful talk today. We've got just an announcement to make. We've reached the end of the 2014 QI Connect series, and it has been an astounding year. You can find all of the recordings on the link that Ross posted earlier on in the call and on our website, or just Google QI Connect Healthcare Improvement Scotland. However, look what we've got in store for 2015. We've got Beth Lidger from the Danish Safety Programme. We have Professor Mary Dixon-Woods, possibly the most published social anthropologist and Professor of Sociology and Health Sciences at Leicester. We have the outstanding international leader with Maureen Bisignano, and we have Dr. Jennifer Dixon, the Chief Executive of the Health Foundation. These are just 4 of what will be an amazing lineup that we'll send out to you early in the new year. We'll send these dates out as well. But just a final thank you to the team in Healthcare Improvement Scotland for bringing this amazing series together. To Jennifer, to Ross, to Carmen, and to the others who've helped us through the year. Thank you very much indeed. So listen, this is the end of this series. Thank you all very much. You'll find the recordings, as we said. We'll be in touch with your certificates of attendance, and have a great rest of the day, and Merry Christmas when it comes. Thank you all very much.